U kunt op plaats nemen.
Hereby I open this academic ceremony in which Silvia Mariani will defend the academic thesis, current status and targets for improvement in postcardiotomy, extracorporeal life support. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear member of the committee, dear colleagues and dear friends, I'm going to present our research about the current status and targets for improvement in postcardiotomy extracorporeal life support. So as a cardiac surgeon, I know that modern cardiac surgery is facing a lot of challenges. Patients that require a cardiac operation are often very sick with a very damaged heart. So we are not only taking care of the heart in the operation room, but we are getting used to treat patients which are getting older, with heart failure, with a heart which is very damaged, or also with the kidney problems, or liver problems, and other organs problems. And we are also operating very complex cases. For example, in the past, we were doing a lot of bypass surgery, which is now shifting toward PCI and less invasive techniques. But nowadays, we are taking care of patients with heart rupture, for example, or with the vessel big problem, when the big vessels like the aorta rupture. So these are really high-risk procedures, and the risk lays in high-frequency complications, such as the postcardiotomy shock. What is the postcardiotomy shock? It's a situation where the heart is struggling. And when the heart struggles, the blood pressure goes down in the whole body. Then all the organs are suffering, liver, kidneys, and the whole body shuts down. Then the heart gets even worse. And this is happening up to 4% of cardiac surgery patients. The consequences are morbidity, so the patients get sick, or mortality, up to 70% at 1 year after surgery. We can do something to help these patients. We can help them with what is called ECLS, extracorporeal life support. What does this thing do? We stop the process of the blood pressure going down. Then we give organs time to rest, so the whole body can get better, and also the heart gets better. The whole circle stops, and we can get better patients at the end. What is this ECLS? It's the abbreviation for extracorporeal life support. It's a heart-lung machine that we can use for days and weeks to support the organs and allow the heart and the lungs to recover. It's a machine that takes the blood out from the patient, from this cannula, and then this blood goes in a sort of mechanical heart, which pumps the blood through mechanical lungs and back to the patient. Everything is controlled by a computer, which is the brain of this machine. As you can imagine, this is a very complex support and treatment for the patient, which is characterized by some unknown areas. So sometimes it can be chaotic, and we still have a lot of questions. With our research, we try to put order in this chaos and target specific topics for improvements in the future. So we started from the questions that we had. For example, how good is ECLS when we consider big populations? Or if all the patients are the same, all the patients we're treating, when do we start ECLS? How we start it, with which techniques? But also, how do we manage it? But at the end, why still patients die after this ECLS? And why they die even when they discharge, they go home? To answer all these questions, we set several methods. We worked with groups of experts from the ELSO, the Worldwide Society for Extracorporeal Life Support. We took some surveys among experts and hospitals. We analyzed the national data from the Netherlands, and we set up an international study collecting data from 16 countries and 34 centers. The name was PELS. So we started with the first question: how much do we use ECLS? Over years, from 1995 to 2020, we saw that we were using this ECLS more and more. Numbers were going up. But what about mortality? More than half of these patients, they were still dying. And we ask ourselves when and why these patients are dying. When? We analyzed the flow of these patients, and we noticed that up to 36% of these patients, they die while they are still treated with this ECLS. And the 23% of these patients, they die after we stop the ECLS, so or even when they go home. So in total, up to 60% of all these patients, they die in hospital. But what happens when they go home, as we said? More than 1/3 of these patients, after discharge, they might die. And these are data from 2013 to 2019. But if they manage to survive the first year, then the overall survival is quite good, up to 66%. So we have to do something in hospital and during the first year after discharge. But why does one patient survive and the other not? We started from some stereotypes, like female and obese patients are no good for ECLS because they have higher mortality and they're difficult patients. We analyzed a population of 40% of females, and we stratified the population based on the BMI. What we notice is that actually they do not die more, they're just different. So every patient has a specific characteristics, and we need to adapt the ECLS to each patient. However, there are some red flags that we need to pay attention to. For example, older patients have higher chance of mortality, of patient after a cardiac arrest, or patient with a specific type of disease, like the right heart disease, patient with lung disease, or if we start the ECLS not during the operation, but after the operation. And you can see these percentages are the increase in mortality. So we might not be able to save every patient in the world, maybe not older patients or after a cardiac arrest or with chronic diseases, but especially we lose patients if we act too late. So what happens if we are too late? In the past, still a lot of people, they say, oh, ECLS is the last resort, we try everything until nothing else works. Then we thought, let's have a look on patients that received an ECLS during or after the operation. And we saw that if a patient received an ECLS in the ICU after the operation, mortality goes to 64%. While if the surgeon started the ECLS in the OR, in the operation room, mortality was lower. So we might save more difficult patients if we start the ECLS during the operation. But so then we wanted to summarize all these timing points. And we identified a specific group of patients that might benefit from starting a support before the operation, for example, to improve blood pressure or improve organs if they're already struggling, for example, after a myocardial infarction. Then we might consider starting ECLS if the patient is too unstable to leave the OR, or if we have doubts, like the patient is at high risk of crash in the ICU. The last group of patients are those patients getting post-operative ECLS, so like the rescue patient after cardiac arrest or failure of other therapies. Our suggestion is to avoid this situation. We don't want to use ECLS only as a rescue, but we want to act before or during the operation. But how do we do this? How do we start this ECLS? As you saw, it's a complex machine with cannulas and tubing. We need to evaluate the ECLS setting very well. For example, based on the type of surgery that the patient had, full sternotomy, like the traditional bypass, or maybe just a small incision. Then we have to analyze what the patient needs, so which are the organs that are struggling and we want to help. But also, the characteristics of the patients, as we saw before. Patient is bigger or smaller, or we want the patient awake and deambulating and walking around. All these factors should be considered by the surgeon, intensivist, and anesthetist while starting the ECLS. How do we manage it? So we ask a lot of centers to tell us what they do with, for example, medication, lab tests, monitoring, or setting of the ECLS to understand what is the most common way of managing this support. And we notice that there is so much confusion. We really need more research and clarity because every center is like doing something different. So are all these factors contributing to mortality? Why do these patients die even after we stop the support? We talk about the red flags, we talk about the timing, if we start too late, and we talk about the confusion in management of these supports. But also, ECLS patients are very fragile, and their condition can change from moment to moment due to complications. So we analyze also complications, and we notice that 60% of these patients, they experience some bleeding, or new kidney injury, or severe infection, or in 1/3 of this patient, all the organs are failing. So complications are still quite frequent, and complications lead to death, even after ECLS or discharge. So we must work together, not only when we start the ECLS, but also during and after to prevent complication. So in conclusion, what we learned about the patient's journey that starts before the operation. When we select the patient, we need to talk with the patient about the chance that he or she might not get an ECLS. But also we need to consider prophylactic approach. So let's evaluate if we want to start an ECLS before it's too late. Then in the OR, we should recognize early the patients that are at high risk, and we should not wait. Sometimes it's also better to plan in advance and choose the best technique before being in the emergency situation. When the patient goes to the ICU, the ECLS team should work as a real team, all together, surgeons, anesthetists, intensivists, perfusionists, nurses, and so on. We should be dynamic, be very careful in the first 24, 48 hours, because those are the most risky hours. And we need to, again, act before it's too late. But when the patient goes home, we should not leave the patient. We should follow and support our patients. We should monitor patients for at least 12 months, and this will improve long-term survival if we prevent all these complications. So the big take-home message is that a path, the ECLS path after cardiac surgery, is formed by laying one stone at a time. So we start from the beginning before surgery until when the patient goes home, and everybody should put one stone next to the other one and form this nice path. So thank you.
Thank you for your presentation. The opposition will be opened by Professor Jore, Professor Health Technology Assessment at this university. Professor Jore was the chair of the assessment committee.
Thank you, Mr. Prorector. Dear candidate, I feel a bit outnumbered as a woman. So I'm really glad you are here too today. And I do think we have important roles. So let's not minimize our roles, and good luck. I read your thesis, and I almost always start that to say that a PhD candidate wrote an impressive thesis, because that is almost always the case. But in your case, I was a bit scared when I opened the manuscript, because 10 studies. And then I received your book, and I saw that there is a publication list with 103 publications. So I think you're guilty of overperforming here. But my congratulations. It's a wonderful piece of work, and also, of course, to your supervisors. But I do have a question, of course, because that is why I'm here today. And I was very happy to read what you said about the value of qualitative methods and also the value of descriptive studies, of registries, also in comparison to RCTs. And that is, of course, also where my work is. And one of the things that I find important is to always try to find the appropriate research design for a certain research question. So that is where I want to have a little discussion with you about. You did a whole bunch of observational studies, beautiful. And then in your discussion you said, yes, but there were some poorly designed RCTs in the past. And we even, that has really drawn us back, right? That has really halted innovation. And I was wondering, did you really state that, meaning that that is a reason not to do RCTs anymore? What did you mean with that observation?
Highly esteemed opponents, many thanks for your comments and your questions. Actually, the point is not that we should not do RCTs. The point is that methodology should be really discussed and thought and to the point based on what our clinical question is. And this is part of the history of ECLS. There were some studies with some problems in the first years, and that brought to demonstration that ECLS is not working, and that stopped ECLS for many, many years, until the first randomized trial, which was properly designed, let's say, was the Thesis trial and demonstrated the efficacy and the cost effectiveness of VV ECMO. Yeah. So the point is we should really focus on methodology.
Yeah, better trials. Yeah, and you see what a responsibility we have to do good research, right? You do suggest to do a certain RCT on cannulation technology. I'm not going to pretend that I know what that is, because I frankly do not have any clue. But why? What were your arguments, your generic arguments, to pinpoint that topic for an RCT, and not probably the hundreds of other topics that are also mentioned as areas for further research in your thesis?
The point is that that's the beginning when we start the ECLS. So actually that's the second step. The first step is patient selection. And that's not what we should solve with an RCT, but the first step is when you put cannulas in. And we are still not sure which is the best method. So we use different entry points, let's say, from here, from the chest, from the groin, and we still do not know which is the best. And we cannot solve that question just with observational studies, because there are so many bias of selection. Yeah. Just the first one, the groin vessels are not good, so I go up, or the other way around. So we never get clean data for this. And that was like a methodological point. Let's say, let's start from the beginning. And that's also probably the most surgical point, which is my field as a cardiac surgeon. Yeah,
which is your expertise. Yeah. One other question. Later you talk about the registries that are important, that you think can be even more important. And there you also state that those registries should contain information on the context where the treatments have taken place, some information about the policy, some information about the center. No qualitative research anymore. Why would you now abandon qualitative research? Do you still see reasons to perform qualitative research later on?
Yeah, definitely. The point of talking about considering the environment is mainly because it started from that survey that showed us that every center is doing something different. And we were just discussing also today with clinical colleagues, and everybody says, no, I use this drug, or, oh, no, I prefer to use this drug, or, no, I think this drug is better. So if we work on observational studies and we don't put in the context drug use, monitoring, or just also the timing of stop ECLS, then we are like comparing pears and apples. So we really need to contextualize, to have a context on where the research was done. And that's why we consider the variable center in all our studies. And for example, in the logistic regression, we always use the random effect to control for clustering in time and center.
And then you would know, or at least know better, what variability is there and what drives that. you do not know why that variability is there. What could you do to understand that better?
That's an extremely good question, and I think the answer is very difficult, at least in our field as cardiac surgery, because the healthcare system is different, ethics are different, so it's really difficult to, put one level for everybody. So we can ask, we can discuss, but it's very difficult to change ethics of a country, for example. And I work in Italy, in the Netherlands, in the UK, in Germany, and I'll tell you it's very different. So if maybe in one country I say, okay, this patient is done, I stop the treatment, the other country say, I want to go on. So that's almost impossible to remove this variable from the studies. Also RCTs, for the best RCT is usually designed in one country or in a bunch of small number of countries, and sometimes might not be applicable in other parts of the world. So this is something, we are humans. So it goes back to the fact that we are humans, and we should contextualize this.
Yeah, I think that's very important. I always say you have to embrace the complexity and not ignore it. It is important, I think, in the sense that you have to distinguish between knowledge gaps and really understanding, for instance, implementation hurdles or system dynamics that would lead to, different use of technologies, etc., etc. For that, qualitative research can be very, very handy. So I hope that you continue to interview your peers, because I think with your international experience and your and your clinical background, you're excellent for that. I'm happy with the answers. Thank you.
Thank you. The opposition will be continued by Professor Havrich, Professor Cardiothoracic Surgery at the Hanover Medical School. Professor Havrich was member of the assessment committee, and we highly appreciate your participation to this academic ceremony.
Thank you, dear Rector. Dear candidate, this candidate was working in Hanover in the experimental field of cardiothoracic surgery, dealing with extracorporeal life support. In 2020, and in 2020, you remember, was the year where the most significant isolated disease, which was corona at that time, was the cause for introducing extracorporeal life support and ECMO. At the time, we got data from this candidate from northern Italian statistics, and Italy was about 2 weeks ahead of Germany. So her information every morning, 7 o'clock, about the statistics of the development of the disease in Italy gave us the opportunity as a prompt reaction. And her data went through my office to the Prime Minister of Lower Saxony, from there directly to Berlin, and that gave us the opportunity to make the lockdown at the right appropriate place, so we had enough intensive care space. So we in Hanover are still very grateful for that. But yet, I have a number of questions regarding your paper. And the first one is, from my clinical experience, the most problematic cases are those with right ventricular failure, especially after heart transplantation. Now, in this volume, you give us seven different cannulation and support types. Which one would you suggest to use in the presence of pulmonary hypertension?
Highly esteemed opponent, thanks for the question. That's a very interesting question, especially because that's part of the future of our field. And isolated right ventricle support, or with or without oxygenator, is becoming more and more used, especially during COVID time, because we found out, we have a second ventricle, which is the right ventricle, and we should support it. Pulmonary hypertension is probably one of the trickiest situations, because you have to pump against this resistance, and we need to understand first which is the reason of the pulmonary hypertension. And I would, based on that, I would choose if to use the right support, the isolated right support, or to go for VA ECMO, for example, we have pulmonary hypertension is secondary to left heart disease. I would go probably, the problem is the left, then I go with an VA ECMO. If it's primitive pulmonary hypertension, we can consider the right ventricular support. But the future is, the point also of the message that I want to give also with our research is that it's no more just VA ECMO overall for every patient, but we should really think what is the cause and the situation of the patient and then choose the best support. Sometimes also the most difficult supports like triple cannulation or VV, ECMO and so on. We start from the basics, but we need to really focus that every patient is different.
Thank you. Can I ask a second question, please? Now, you're a well-acknowledged expert in the field of extracorporeal life support, so one country asks you to put up an institute, a research institute for extracorporeal life support. And there are surgeons, there are intensivists, and there's also industry. My question to you is, what would be the prime target for you or the research topic you would suggest to the surgeon? What research topic would you suggest to the intensivists, and what topics for research would you suggest to industry?
That's also a very good question, and I hope it's going to be a reality in the future. As a surgeon, I would start with a cannulation. That is the beginning of the setting. So it's a consequence of understanding the disease, and is the more practical and technical part for surgeons. As intensivists, probably I would go for coagulation, because we still do not know enough, and we still have, that's the most problem probably in the ICU. And as company, I would probably also focus on working on, together with intensivists, with the coagulation and durability of the device. Miniaturization is at a good point, and I think the next step is the implantable lung, as we discussed several times. But I would focus mainly on these two topics, and companies should also focus on that.
Thank you.
Thank you. The opposition will be continued by Professor Peak, Professor Cardiothoracic Surgery at the University of Florida. Professor Peak was also member of the assessment committee, and also for you, thank you for joining us at this academic ceremony.
Thank you, Mr. Prorector. Dear candidate, I would like to congratulate you on your career so far and on this excellent thesis, which was a pleasure to read, and I think is very important in the current era as cardiac ECMO is becoming more and more prevalent around the world. So I'd like to ask you, given how important case selection is in achieving good ECMO outcomes, how do we ensure good case selection when surgeons are operating on patients who are bad ECMO candidates by definition, because they are high-risk surgical cases and are therefore also by definition at high risk of ECMO, particularly in an environment where cardiac surgical outcomes are publicly reported on an individual surgeon basis, and surgeons are then shamed at their poor outcomes, which makes the surgeons extraordinarily invested in avoiding a perioperative death. So how can we square that circle?
Highly esteemed opponent, thanks for the question. It's also one of the points I really discuss in the clinical field. I would highlight 2 points. First, we should never let the surgeon or the intensivist decide alone, or the anesthetist decide alone. We are moving toward a team, and should be a team effort and team discussion. Second point, I repeated several times, we should prevent, we should act early, and we should discuss about ECLS awareness before. So it happens last week, I discussed with colleagues, it was a very difficult case with sky-high mortality chances, and we need to discuss before if this is an ECLS candidate or not, especially because, okay, there are emergencies, dissection going directly to the OR, and we don't have time, but most of our cases are elective or urgent. They are in the ward for at least 24 hours. We have plenty of time to plan in advance and discuss together with the patient if it's awake and the families. So it's not something that should be decided when we are at the table, oh my God, what's happening? We have to have a plan before.
I completely agree. My second question is, how can we reduce the ECMO gap? So in other words, people that successfully come off ECMO and are decannulated but then go on to die. How could we improve survival in that cohort of patients?
We don't have one strategy. We have multiple strategies, of course, because we have multiple complications. Starting from one is the research point, coagulation and bleeding. We still need to do research, but also we need to work in a structured way. It's not that everybody comes in and somebody does something different. Oh, this is bleeding, I stop the heparin, or this is not bleeding, I put bivalirudin and so on. So we need to research on the coagulation side. We need to wash hands because infections are still quite a high rate in some countries, especially multi-resistance infections in some countries, as in Italy, for example, are really raising. So we should wash hands in the meaning that we should work properly with medication, with wound dressing and so on, cannulation, and also with antibiotics. We don't want to waste antibiotics. Third is kidney failure. Kidney failure is also difficult to tackle. We also still do not know enough about this, but the good management of kidneys should start before the ECLS again, in the OR, for example, with good perfusion of the kidneys, with good balance of the fluids, and so on. So I think these are if we tackle these three main fields, we will reduce a good percentage complications, which are complications that are affecting survival after discharge. Kidney failure and sepsis, we demonstrated that there are associated with post-discharge mortality. So we need to tackle those with these strategies.
Thank you, dear candidate. Thank you, Mr. Pro-Rector. I'm satisfied with the responses.
Thank you. The opposition will be continued by Professor Hacking, Professor Biochemistry at this university. Professor Hacking was member of the assessment committee and he is the secretary of this degree committee.
Thank you very much, Mr. Pro-Rector. Dear candidate, I first like to compliment you on your thesis and was already alluded to by the chair of your assessment committee, Professor Jore. It's a massive amount of output. It's what I counted as 54 posters, 24 oral contributions, international conferences, 10 book chapters, which is really rare for a young person like you are. I thought there's always like for the elderly to write book chapters, and also 104 peer-reviewed papers that led actually to a HERS index of 16. And that's not allowed in competition, but here we are today to let you shine. So then it's, I think it's allowed. Also the artwork, I really appreciate, and I was just wondering why you chose for the black and white version on your cover. But maybe you can shortly respond to that. Of course, these compliments also extend to your promotion team, Professors Rousseau, Maas, and of course Dr. van Bussel. I'd like to discuss with you the topic of thrombosis, as you already might have expected, but also the nomenclature and the prevention of thrombosis and/or, I think, what is the biggest problem, clotting in the device. All ECMO patients, they receive first-line heparin, but still within 5 or 20% of cases, secondary or second-line anticoagulants are withheld. Do you have an idea if those are patients that develop post-operative thrombosis?
Highly esteemed opponent, thanks for the double question. I would like to start with the artwork first. So 2 reasons, because the book cover should have looked like, you know, you're at school with a blackboard and white chalk. That's because of teaching, and I hope this is going to be, you know, the beginning of also teaching for people. Black and white, because we start from black and white, because we are at that level, and we need to put colors with our research and go on and on until we get the full picture colored. Second,
really well thought through. Yeah, thank you.
Second question. about the withheld of the anticoagulation in this patient. So I think in postcardiotomy patients, the main problem is bleeding, and a lot of people are really afraid of treating this imbalance with the circuit thrombosis.
Right.
So surgeons, they will always push toward, oh, please don't give heparin, while the intensivists and perfusionists might be scared of this. And since we haven't understood yet what to do, I think the answer of somebody who is also scared, let's say we're human again, it's just, oh, I stop everything and let's see what's happening. We don't have a direction so far, so every center is kind of doing everything different. Heparin, as you noticed, was the main choice in most center. We have alternatives coming up. We have argatroban, bivalirudin. We discussed the use of nitric oxide and oxygenator, but probably so far the most common is heparin, just because it's the cheapest.
For me, the most amazing part, if I can interrupt you, is like the decision model, because you said, well, if you look at the table, for example, the table 6.2, that's the anticoagulation start. 75% is based on bleeding. So to me, that sounds a bit strange. So if you read patients start to bleed, then we give anticoagulants. I think that's not really what you mean with that. But basically, then you also say the anticoagulation start based on bleeding is based on page 140 on a subjective judgment of reduced post-operative bleeding. And then it's sort of summarized in a table, supplemental table. But if I look at that table, I got it from the internet, basically the APTTs and the ACTs in presence of heparin, they're normal. They're all normal. So how can you decide on normal APTT and ACTs if you're going to administer secondary anticoagulation? What would you do? What would be your criterion, and not with all the other studies? When would you give this secondary anticoagulation?
So let's say, divide your questions in subparts. The point about bleeding, I really want to highlight it because surgeons are just not using standardized way of judging bleeding. Even if there are international agreement and standards to define surgical bleeding, and there are some position papers saying a bleeding which is less than this or that, surgeons are still doing, this is my patient, this is my opinion, I decide. Yeah. And the second question, if I understood correctly, your point is about the use of APTT and ACT in this patient.
Yes, you have used them, or at least the centers have used them. And the cumulative summary says that all these values were actually within the normal range, considering there's heparin present. So they double or sometimes triple.
Yeah, that's
But then still on those subjective measurements, they decided to give secondary or second-line anticoagulation. So this is what I don't understand.
Yeah, the point is that many people, as I said, there are every different kind of protocols in every center. So some people, they don't even titrate based on those values. They just use that kind of anticoagulants, or maybe those values are correct, but the patient developed a heparin-induced thrombocytopenia, which is quite often in this patient. So in my experience, that's probably the first reason of changing anticoagulant in our patients. Right. So even if all lab values are in range or are normal, but the patient got a heparin-induced thrombocytopenia, and you see the platelets dropping down and the circuit gets thrombosis and so on, then that's probably the main cause of switching the anticoagulation to something alternative.
I do understand your challenge here is that during the procedure, your biggest worry is the device clotting, and then, of course, then the secondary, maybe the more dangerous, is the patient pathology of thrombosis. I could discuss this for hours with you, but I'm very happy with your answers, and I give the word back to the prorector.
Thank you. The opposition will be continued by Dr. Spekenbrink, cardiothoracic surgeon at the Medical Center Twente.
Thank you, Mr. Prorector, for giving me the opportunity and privilege to take part in this ceremony. Esteemed candidate, dear Silvia.
Can you push the button, please?
Sorry?
Push the button in front of you for the mic.
I have. I have. Dear candidate, first of all, I would like to congratulate you on your great cross-border accomplishment. It's something really remarkable. I was very aware that you're an excellent surgeon, and now it is clear to everyone that you're an excellent researcher as well. My compliments. And of course, I would like to also give my appreciation to the promoters and co-promoter. I've read your thesis, of course, with great joy. And I was puzzled already in the beginning because several times in the first chapters it was stated that with peripheral cannulation, LV afterload is increased. And I was puzzled and I thought about it a bit. The left ventricular afterload is defined by the law of Laplace-Young. And in a simple balloon, it is the pressure inside and the radius of the balloon. And that's a measure for the wall tension, the wall stress. And if you translate that to the left ventricle, then it is the left ventricular pressure and the radius of the left ventricle and the wall thickness. These are the components of afterload. But these components don't describe anything about cannulation, peripheral central cannulation, direction of flow. So I was wondering, if you reconsider this, do you still maintain that with peripheral cannulation, peripheral flow, LV afterload is increased?
Esteemed opponent, thanks for this question, which is a topic that I really like. So actually, we should consider that with a peripheral cannulation, we have a backflow in the aorta. And this is like, for the heart, is like pumping against a wall sometimes, especially if we have myocardial damage. And especially if we are not managing pressures in the best way. So we are increasing the endoventricular pressures for this reason, because we're just pumping against a wall, especially if we have some degree of valve regurgitation, aortic valve regurgitation, then the pressures in the ventricle increase more and more. It's not only about the peripheral cannulation, because nowadays we are also understanding that also the central cannulation does this, especially depending on how we put the cannula, because it's just, and which type of cannula we use. A curved cannula in the upper part of the aorta directed toward the arch is going in the direction of the flow, while if you just put an AOPA cannula at the ascending aorta, just the flow, it goes to the posterior wall and then against the valve. So let's say the peripheral cannulation is the most common, so we are sure about that. About the central cannulation, it depends how we cannulate. So it goes back to the surgeon's responsibility to be aware of how you cannulate. Subclavian cannulation, that also increases a certain amount of afterload, but we have a better perfusion of the head. Even if we analyze our data, we found out that the stroke rate was higher with the subclavian cannulation. So the point of the discussion of the peripheral cannulation was mainly about that. It's the most common one, is the easiest way to understand this. Well, the ascending aorta can vary, depending on where I put the cannula.
And if we would go back to the balloon that Laplace used, do you really think it matters if we would push in extra volume from this side or from this side, that it affects the wall stress? Because I think the exact same situation is applied or is applicable in a circulation, in systemic circulation. It's under pressure, and from either side you give extra volume, so you would increase the pressure, and it flows away through peripheral resistance.
Yeah, and also if for example, I have a systemic pressure, which is not 60 main arterial pressure, but I have 110 of main arterial pressure, I get the same effect of increasing the afterload of the heart, and then I get the same effect of backflow coming from the aorta, from the peripheral cannulation. So it's not only the place of the cannulation, it's thinking about the physiology, and also in that case, we need to, of course, address all the different aspects of this physiology.
Thank you. We'll discuss this later on, I think. But I have one more question, if I may. You know that ECMO or ECLS is in the armamentarium of every cardiac surgeon, because we all have cases that go bad, that go wrong. And you already said we should discuss this beforehand, we should have a plan. But it is fortunately a circumstance that doesn't happen every day, every week, every month. In most centers, it's a few times a year. In those centers, should they keep those ECMO patients in their own center, or would it be advisable to transfer them to a center that has more experience because they do other indications for ECMO as well?
I would definitely build a network and agree with the referring centers and transfer the patient to an expert center, especially if the patient is a candidate for VAD or heart transplant. So that should be done, again, in advance, building a network. So every peripheral hospital should have a referring hospital, and the referring hospital should, let's say, share indications, share patient selection and methods with the peripheral hospitals, and then as soon as possible transfer the patient to a referring center. That would be my advice.
I thought so. Thank you very much.
Thank you. The opposition will be continued by Dr. Meeuwissen, cardiologist, intensivist at the Erasmus Medical Center, Rotterdam.
Thank you very much, Pro-Rector. Dear candidate, also from my side, my congratulations for this immense work and for your incredible career so far, also from, let's say, personal journey. Also my congratulations to your supervisor, your team, who has been with you along the way. I would actually like to question you on the obesity paradox. And I would like to start off with the conclusions you draw in chapter 9 and 11, which seem, in a certain sense, on the opposite way. So in chapter 9, you conclude that ECMO support should be carefully considered in patients with higher BMI, whereas in chapter 11, you have done a specific analysis on the effects of BMI, and you conclude the opposite. Can you help me to understand this apparent divergence?
Esteemed opponent, thanks for this question, also because this highlights the way we worked. So the first study you mentioned was done first and raised the question, and that was done specifically in the Netherlands. And in that study, we also found that the obese patients were also the older patients. And we know that age is the main variable associated with mortality in this field. We couldn't really, let's say, split the effects of obesity and age in the Netherlands, and we had to contextualize, going back to the first questions, in this country. But this raised the question, and we decided to analyze this question in a second population, which is not just a country, but several countries together. And this was meant also to test the validity of the external validity of our findings. And when we analyze in the larger population, which is not, as I said, local, but international, we couldn't confirm this finding. So again, it should be, let's say, contextualized to the countries. As what I learned from both studies, one generating the question and the other trying to confirm or not the question, is that probably I wouldn't exclude a patient just because of obesity, because we couldn't confirm the validity of our finding, which were local in an international court.
Yeah, thank you. Talking a little bit deeper about methodology. So in chapter 11, that's a more focused analysis on the BMI. I studied this well-executed analysis, but I wondered, you specifically chose to correct for some variables, which you reason are potentially confounders. But if you look at them the other way, then hypertension, diabetes, reduced ejection fraction could also be a consequence of, let's say, high BMI. So to say they could be in the causal pathway. And when you would adjust for those factors, then you could also, let's say, falsely take away the effect. What is your opinion on this?
That's absolutely correct, and but that's also reality. I mean, I don't get an obese patient without metabolic syndrome or without hypertension. Usually that's the kind of patient that we have, so that we have to stick to what we see in clinics, and that's why we decided those variables to be included in the model to adjust for obesity. Of course, we don't have the perfect answer. We cannot really isolate that only variable and the effect of that only variable, but that's also the way we treat our patients. Our patients, they never come just with obesity and nothing else. So that's why we decided to adjust based on our clinical experience and the clinical international experience.
Yeah. So if I understand correctly, then BMI could be considered as a reflection of multiple other things. So me as a clinician in the Netherlands should be focused on BMI and selecting patients on basis of that. Is that correct? Or?
I wouldn't select patients based only on BMI, even if we are in the Netherlands. It's the same for female. We saw exactly the same effect in the other study. It was not sex that was associated with mortality, but or with outcomes, but these are different patients. They come with different diseases. So you really need to consider all these points when you choose your patients. You can't just say, oh, this is obese patient, it's not going to work, I exclude the patient. You really need to consider the patient as a whole.
Yeah, that is very much agree with that, of course. One final aspect from my side, in the discussion you also touched upon the concept of collider stratification bias, which you could maybe also hold here, that you as surgeons meet patients in preoperative setting and you talk to them and you see how they're doing. Could that have affected this association as well? And how should we, or you, correct for that in your analysis or adjust the results?
Yeah, that's absolutely something that can happen, and it happens in clinical practice as it happens in science. What we applied in all our research is, again, starting from the clinical observation and our clinical experience. And we know that we tested also for colliders, and we know that some variables, they come together. So we know we cannot delay this effect. Somehow we try to control, we try to adjust for variables, we test for multicollinearity, we test it, we try to apply for what we could, the statistical methods to adjust for that, but that's everything starting from the clinical work, from the clinical observation, and some things you cannot really, isolate that only variable, especially if you start from an observational study where you don't have, especially in a retrospective studies, where we have the recall bias, for example, so some data we couldn't find them. You have a selection bias in patients, so you have a lot of bias that play in this direction.
Yeah. So as a surgeon, how if you would meet a patient in the preoperative setting, for example, a class 3 obese patient, according to your thesis, how would you approach this patient differently than let's say a patient with a normal BMI? What is your clinical opinion on this?
Well, actually, we discussed again clinically a few weeks ago, because I operated on this patient on 130 kilos, and all the other surgeons were like, oh, no, this patient is going to die. But he did it perfectly and went home went discharged 5 days after. So that's not an exclusion. It's not an exclusion for ECMO. It's not an exclusion for surgery. Of course, we need to be aware that they have higher risk of, for example, a wound reopening if they don't behave properly after surgery. So try to prevent, instruct the patient on what he can do. Or if it's a patient that can wait, maybe you can help the patient losing weight before surgery. That's what we did several times. If it's a patient that can wait, not all of them, they can. So I would, as obesity, many other things, social problems as well, so social support after discharge. These are all problems that we should address before when we meet the patient first. Yeah, so but I wouldn't exclude per se an obese patient.
But you are more focused on additional things in patients with high BMI, if I understand correctly. Yeah.
Is it?
So you're more focused on, let's say, additional parameters, additional information when deciding on surgery, yes or no. Yeah.
Yeah, it's not only the obesity or the BMI parameter. It's all, of course, if I have a 95-year-old patient and with a BMI of 30, it's different than having a 25-year-old patient with BMI of 30. So we have scores to evaluate these points. None of them is including really the BMI, and also in clinical practice they are not really applied. I mean, we have the Euroscore 2, which most of the times is just remain on paper, and sometimes surgeons they keep operating even if the Euroscore 2 is very high, or they refuse a patient if the Euroscore 2 is low, but for example is a liver failure, which is not considering that score. Yeah. So the answer for everything, we don't have it, and we need to decide also together with the patient.
Thank you very much. I'm very satisfied.
Thank you. The opposition will be continued by Dr. Driesen, cardiologist intensivist at the Maastricht Medical Center.
Thank you, Mr. Prorector. Dear candidate, also from my side, my congratulations on an excellent, extensive thesis. Very impressive work, important contributions to the field of cardiac surgery, but also intensive care. Of course, I would also like to involve the promotion team in my congratulations. I think you and your team made the most of these retrospective data with very sound methodology. So very good work. As I only stand here between this moment and the Hora Est in a moment, I would also take the opportunity to discuss with you on some matters. And maybe I can ask one of the paranims to please read out Proposition 4.
Improvement in postcardiotomy ECLS outcome are driven by a multidisciplinary approach with surgeon and intensivists working together towards a common goal. This thesis.
Thank you. So you promote teamwork and you also stress that in your presentation, and I completely agree on that. But if I read your thesis, in several chapters you also stress the importance of an ECLS specialist. You mentioned this term, for instance, in chapter 6, where you state that 50% of the centers have a dedicated ECLS specialist. And I was really curious, what is an ECLS specialist? Is it a surgeon, or is it an intensivist, or is it a perfusionist, or none of those? And can you please go into those roles, please?
Esteemed opponent, thanks for this question. This is a very debated topic because that changes country by country. So when I was a trainee, I did also the ECLS specialist training in Leicester, and so I became on paper ECLS specialist. Mainly, this definition includes nurses and perfusionists, which are bedside management of these patients. That means trained nurses or trained perfusionists that take care of the patient all the time with expertise on the machine and that kind of patients. So it's not that everybody that passes by can manage the machine. Since there is not one international definition, well, there are some direction, but every country is different based on the schooling system for nurses and perfusionists and so on. We did, with the EuroELSO committee, we did an international survey on this topic, on the role, especially now we are concentrating on the role of the perfusionist. It's coming also about the nurses to try to understand what people are doing and what they think as the definition of ECLS specialists. We are analyzing data. We got so far about 200 centers sending back questions, and we are hoping to submit a Maastricht for the EuroELSO Congress next year. So.
Okay, well, I think that's a very important topic indeed. So you say it has to be someone who is at the bedside, so maybe a perfusionist or a nurse. Discussed a little bit before this, and I think we agree. But for instance, many centers have a limited availability of a perfusionist. It's not 24 hours around the clock. How do you think about that? How should we work around this?
Yeah, what we got also from the first results of this survey is that the perfusionist is responsible for the priming and the setting up of the machine, but it's usually not staying there 24/7. It's on call. If it's in a hospital, some centers they have in hospital perfusionists, mainly it's on call, and is the bedside nurse, which is specialized on ECMO, to stay there. Mm-hmm. Some centers cannot even afford to have specialized nurses. So again, we need to work together with the scientific society to try to support. But this goes back again to the question about centers. It's different if I have two nurses, one taking care of the patient, one taking care of the machine, a perfusionist in-house, and surgeons and intensivists specialized on MCS and heart failure. That's different from a center that doesn't have all this, and results will be also different.
Exactly, and maybe you mentioned all the disciplines. Who, in your opinion, holds the final responsibility on the machine and the patient care?
I think at the end, it's not just one person, but at the end, I think it's the surgeon and the intensivist. I think mainly because that's also the way the system works nowadays. So at the end, during the rounds or the handover, we decide about patients. Nurses and perfusionists should be a little bit more involved nowadays because sometimes we forget about that. But that's also a very important part of our work. It's difficult to find one person responsible for something, and especially in the context that we emphasize the team. Also because I think also working in the ECLS field can be also psychological, from a psychological point of view, very difficult and for intensivists, for nurses, or especially when we have to decide to withdraw the therapy. So it's not only one person that should bring the responsibility, it's the team, and it's a heart failure team or MCS team.
Okay, thank you.
Silvia Mariani, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room. Silvia Mariani, the degree committee here present has assessed the quality of your thesis and your defense in view of its positive verdict and taken into account your previous qualifications. The degree committee has decided to grant you the degree of doctor. Professor Lorosso is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Silvia Mariani, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university. Dear Dr. Mariani, I don't know, did I call you Dr. Mariani anytime?
No.
Dear Silvia, well, we thought about this moment many times. And it seems yesterday when we met, I think in Milan was the very first time, and then Maastricht in 2017, discussing your request for a PhD fellow position and the potential topics for such a project. We approach a challenging yet stimulating setting, which is the postoperative cardiogenic shock treated with extracorporeal support, as you clearly showed us during your presentation. Despite the relevance of the argument and the rather disappointing results in such a setting, our research group, with other fellows, as you know, we already address with some efforts and scientific activities this direction. However, together with the initial help, if you remember, with Dr. Heutz, the PEARL study was designed, arranged and implemented in Maastricht, ending with 34 centers and 16 countries around the world, as you pointed out. But your coordination has been outstanding proof of efficacy, dedication, commitment, and supervision of all the participating teams and members. We were able to enroll more than 2,000 patients, making the PEARL study the most relevant clinical investigation on postcardiotomy, shock, and the use of ECLS. With more than 10 papers published in the most influential journals of the specialty, invitation to the most important congresses around the world, and with the worldwide recognition of the research team and the work you have done, making the Maastricht University Medical Center and carrying, and also thanks to your guidance recognized by the vast majority of cardiac surgery centers, cardiac surgery ICU, and related communities. The PELS study database is still producing additional investigation with other 4 or 6 papers ongoing, already submitted, being again the proof that once good dedication, proper people, and appropriate motivation are behind a good research idea, the results will come with great satisfaction. Obviously with efforts, sacrifices, and hard work, but they come. A new adventure, I underline. The PELS-2 study is starting, not easily, but we know it will be another success. We know. Your work in the scientific community has been already appreciated. You have been just appointed member of the scientific committee, or also you achieved recognition of associate professor in Italy. You are supervising at least at other 6, 7 other PhD fellows of my group. So, an already very successful pathway and academic career, which I'm sure will be brilliant and very productive, with other outstanding achievements and recognitions. Your professional scientific careers have been an example of visiting and working in top-level centers and with incomparable giants, Professor Peak, Professor Haberich, to whom we are both very grateful, since both of them transferred to you during your stay at their centers in UK and Germany the passion and curiosity for research, which we do hope will accompany you for the rest of your professional and scientific career. Let me express a special and dedicated applause and appreciation to Guido, your companion who accepted and supported your traveling along your Marco Polo-like traveling. I do not know if you found your Kublai Khan and his teachings and experiences like Marco Polo did, but I have at least a doubt. Now it's time to settle down, hopefully, and build your future plans and take the leading position you deserve, but not forgetting your giants, teachers, and mentors. You had several of them, and all, let me say, they were extraordinary in their peculiarities. Don't relax. I would not recognize this term in your modality, but keep on thinking, working, and generate new research and scientific projects. We really need that from you, and I'm sure we will not be disappointed. Marco Polo wrote in his book Il Milione, The Million, I don't believe that the person travels to come back. Indeed, the person can actually never return to the same point from where he left, since in the meantime, he or she changed and will see his house differently based on his or her experiences. So you will never be the same person. You will never go back to the same place. Generating and finalizing a research is like planning and experiencing a travel. Don't you agree? And at the end, we are not the same person and we are not the same place, even if we did not move from our seat and our table and computer. I'm sure that all your experiences and traveling/papers made profound impact on you as a surgical investigator. But I have my personal request for you, and it refers to what I believe and hope you will be doing as an additional task. Please transfer your passion for research to younger generations. Convince young surgeons you will meet, I'm sure, and work with during your future career how important the surgical research is. Be an example for them and also a reference for their scientific as well as professional career. Show them how fascinating is traveling from their seats and tables, reaching heights and targets which will enhance, finally, patients' care and outcome. We cannot be passive spectators, unfortunately, to the ongoing decline of interest in these activities and attitudes from the young surgical generation. That's a threat. So you have a double task now, heavy and hard, but please do not disappoint us also from this side, but I'm sure you won't. Congratulations and success for your future.
Thank you.
Dear Dr. Mariani, on behalf of the University of Maastricht and the Board of Deans, it's a pleasure for me to congratulate you with this new degree of doctor. In your acknowledgements, you describe your fabulous journey to meet all the medvans who inspired you in your personal and professional life. Probably it will be time, as already expressed by your supervisor, that you are joining those medvans to mentor and coach young clinicians and researchers. We wish you all the best in your future career as cardiac surgeon and as an academic researcher. Hereby, I will close this academic ceremony. Before congratulating the new doctor, we will make a picture with the Dr. Mariani on the stairs in the central hall. Hereby, I close this academic ceremony.